So, okay, Mr. Chairman and all of you, it's a very real pleasure to be here with you. Thank you for the invitation. This is a new and exciting forum for me. My given topic was breast augmentation, the way I do it. Well, this is quite a challenge, especially after Per Heden's talk. But I do my best. And in this audience, most of you are colleagues, plastic surgeons. I'm not trying to teach you anything. I just want to highlight some points which I think that are important and that I hope to be able to give you something to think about. So I live and work in Helsinki, in Finland. Or should I say I work and live in Helsinki. I work at the Hospital Silvetsy in the center of Helsinki. Hospital Silvetsy is a private hospital which was founded quite a long time ago by Matti Pakkanen, and we moved to Helsinki in 1999. This is a private hospital. We are doing mostly aesthetic surgery, but also some reconstructive surgery with trauma and malformations and cancer. So in 2009, we opened a Silvetsy Spa. That's the base. It's also in the center of Helsinki. That's the place where we have our surgical consultations, our follow-ups, other specialty medical consultation. And also we work as a multi-professional team. We have the massage therapists, we have the beauty specialists, we have the specialized nurses. So we try to work as a multi-professional team to get the best results for our patients and clients. At the moment, we are 4 plastic surgeons working full-time. I joined the team 3 years ago. I have no disclosures. Of course, I should say that I wish I had, but I don't. So, breast augmentation, from whom did I learn? Well, I learned from my background in primary breast cancer. I was working there for many years at the Helsinki University Hospital doing primary breast cancer before joining the Silvetsy team. Of course, I've learned from colleagues at work, namely Timo Pakkanen, and all the national and international courses and workshops like ISAPS, and also, as Per just said, the very wonderful Beauty Through Science meetings, where it's always nice to see how after the lectures, the colleagues, including me, let really go and dance on the tables. So that's an excellent meeting. And also we organize at Silvetsy twice a year this Finnish aesthetic teaching symposium, FATS courses, and we had quite many times aesthetic breast cancer subjects. Per Heden has been there for twice. The last time was in 2009. Then we had from Italy Dr. Gino Rigotti, 2010, teaching us about fat grafting and augmentation. And last summer, 2012, we had a real pleasure to have Dr. Elizabeth Hall-Finlay from Canada to teach us. And of course, as we all should, I do learn from my mistakes. So is there anything new in breast augmentation? Any technical points in implant surgery? Well, not really. Is there something with the patient safety, a quality control? I definitely hope so after the PIAP scandal we had a few years ago. I think it showed us all and reminded us of the fact that how really important the quality control and the patient safety are. What about the preoperative planning and postoperative evaluation? Yes, I think there is something new. There's a 3D volumetric imaging systems and measurements. Well, is there anything new in lipotransplantation, fat grafting? In the technique? Yes, I think it's under evolution and discussion. For example, do you do centrifugation? Do we use vacuum-assisted devices? What about the stem cells? What about the pressure measurements? Should they be measured during the fat grafting? What size of syringes do you use? And so on. So it's constantly moving, evaluating. There's changes in that subject. And also for the preoperative planning and postoperative evaluation and measurements. Yes, I think 3D volumetric imaging and measurements is very helpful. So breast augmentation, it is, as often, it is the most common aesthetic breast operation I do. I do it with implantation implants, about 90% of my cases. I do submuscular dual plane pockets. I prefer that, about 90% of my cases. Why? Well, maybe just that in my hands, I'm happy with the results that I get with that pocket. And also some of these ladies who come for breast augmentation, they are really, really skinny. So maybe there's a little less visibility of the implant when it's submuscular versus subglandular. But sometimes people really do want a subglandular implant. They've been in the internet and they say, well, oh, my sister had this. I want the same implant, subglandular. Okay, that's not a trouble. So I can do that. I also, especially, I have quite many these body fitness ladies or bodybuilders, and in that culture, actually, they want the implant to show, and they all want a round implant subglandular. They don't want that I touch their muscle. So I always use textured implants. I like them, and anatomical, 98% round, 2%. When do I do augmentation with fat grafting? Well, if I have a patient who really doesn't want implants, she wants augmentation but done in a natural or bio-organic, whatever how you can call it, way. Okay, well then I see if there's any possibility for that, if she has enough fat. Unfortunately, they are often the very skinny young ladies who have no fat at all, so it's not possible to do a fat grafting augmentation. I don't use fillers, and coming back to the fat grafting, I use the vacuum-assisted devices in less than 10%. Why? Because my patients don't really like the idea. They are not motivated enough to use it as long as it should be used to get some results. And those who do, actually, almost 2/3 of them has to stop the vacuum therapy before the 2 or 4 weeks pre-op because the skin can't take it. So I think the vacuum-assisted devices, theoretically, and also there's been some proof about how they do get more volume when used. It's interesting and the idea is good, but I'm waiting for some product development for more patient comfort before I start to talk about it more to my patients. What are my aims in breast augmentation? Probably the same than to all of you, so that I think the patient safety is one of the most important things. So I only used FDA-approved silicone gel implants, and Silvati Hospital got already in the 1990s this AAAASF quality certification, which means that an external audit of the clinic, of the hospital, is done every 3 years. And we need to self-evaluate all the time, yearly, our operations and the methods we use. Any unaccepted happening is, they are all, for example, there's a post-op hematoma, you have to go take the patient back to the OR. All of these are reported every 6 months. And also, for example, to be able to keep this quality certification, randomly, one operated patient is analyzed by an independent physician, 1 patient per month per surgeon, to see if there are any missing documentation or if everything is correctly documented. So it takes some time, yeah, it's quite tough to keep the certification. Also, as Per said, I think careful planning is very important. You must take time to do that in order to get consistent results, which of course I would like to be long-lasting and natural looking. So to do that and to learn, I continuously analyze my results. I try to be meticulous with my documentation, with the pictures, with the other documentations with the patient. And I also think that a well-informed patient, the better you inform your patient what is possible, what is not possible, what will be the probable outcome, the better patient satisfaction. And that, of course, leads very easily to the fact that these patients keep coming back to you. They come back to you for the belly operation, or they come back to you 10 years after when the breast, well, this is very important, I think, that they have to be well informed. So you get patients for life. So I don't do this, and I definitely hope that you won't do either. It looks awful. And now I'm referring not to the breast size, which I don't like, but look at the quality of the pictures. Is this before and after pictures? What is this? So in Silhouette, we try always to standardize our documentation, take a lot of care to do the pictures well. So the standardized positions of the patients, the background color, background lighting, and of course the patients don't have their own underwear or nothing extra shown in the pictures. So during consultation, I talk a lot. I take my time. Usually it's scheduled 60 minutes. Very often it's a little bit longer than that. Before the consultation, before I see the patient, the 2D and 3D pictures are taken. I have my nurse with me at the consultation. And I carefully try to understand what are the patient's objectives, expectations. I take the full medical history, patient habits. If she's a smoker, I ask to stop immediately. And I also try to get a glimpse of the psychological stability of the patient, because if, as you well know, there are patients who are not stable, and you should stay away from these people, or be very careful when operating on somebody who is not psychologically stable. So I assess, again, as Per said, the quality and quantity of tissues, the breast and the thoracic frame, and also something that Elizabeth Hall-Finley called the breast footprint, which I come back later. So then, based on all this, I do an implant selection, an operative plan, and explain it to the patient, and take time to explain that. Why I want to do this, what is her anatomy, what is possible to do, what is not possible to do, what is possible to achieve, and what is not, unfortunately, not possible to get. And when she understands all that, it's easy to get the assigned informed consent from the patient. Before the operation, radiology, mammography and ultrasound is programmed, and I don't accept it if it's 2 months is the time limit. You know, it can't be longer time before than that. Laboratory tests, that's blood cell count and the antigens for the HIV and hepatitis. And also during the consultation, actually I usually start, but that's because of my breast cancer background, I usually start the consultation by examining clinically the patient and the lymph node areas. I found 2 undiagnosed breast cancers doing that. So, as I told, Elizabeth Hall-Finley visited us last summer, and I think there was a very interesting idea of her way of analyzing the patient. She talked about the natural footprint of the breast, which means, as Per had then also said, that where is the breast located in relation to the thoracic frame? Is it high or is it low? Also, where is the upper border of the breast? And I'm not talking about the upper border of the breast gland, which of course goes much higher, as we all know who've been doing mastectomies. But where is the junction of the chest wall and the breast? And where would you like it to be? Is it very low? Is it very high? Because all this has influence on your implant choice. And I think it really does help you to choose the best possible implant for the patient to get a natural look. And also, it does help also in reductions and mastopexies to analyze these features, in my opinion. And that's quite new. That's only last year that I learned that from Elizabeth. So a few examples. Look at this breast. The upper border, where it takes off the chest wall, is quite low in relation to the preaxillary crease. A naturally beautiful looking breast, usually the upper border is somewhere near the preaxillary crease, which is just under the preaxillary fullness. So the border is here, but I would like to have it to be a little bit upper. So how could I do that? That's what I think when I see the patient. What possibilities do I have? Here's another lady, completely different story. Very skinny. She was tall, 178 or something like that. But look at her breast. It is very upper border is very high already, and at the same time, the whole breast, the footprint is very high, and it's very short in the vertical measurement. This needs for another choice of implant. So the 3D imaging, we have the Scanfield 3D imaging for the studio system from early 2009. I think it's a very useful tool in communication, especially for the implant augmentation patients, because then you are able to do the simulation, which is quite accurate, unless if you have a lot of ptosis, then it's less accurate. And you can show the patient, and this is, you know, the size, volumetric size of your breast, that it will be around this, about this size after the operation. So it's good communication to show the patient what to accept after the operation. Also, standardized documentation is important. We get really good pictures with that. And also for fat grafting, it is excellent for measurement of volumetric measurements before and afterwards doing fat grafts. So here's an example. There's a lady, pre-op. We have a better camera now. That's why this picture is so much better. It's a more better resolution. These two were taken with the same camera. So that's before the operation. This is a simulation, which I showed to my patient. And actually here she is 1 year after the operation. So in this case, I think the actual result looks better than the simulation, which is not always the case. The same in the oblique view. So I asked the patient to look here, to try to see, to imagine the volume, the size of her breast with the implant inside. As I told you, for doctors, for me, the 3D imaging is more interesting when I try to see how much change I've managed to get with fat grafting. So here is a example of a symmetry case where the left breast was much smaller. The fat was taken from the abdomen. Some was put on the right breast and most of it on the left breast. And this shows me what has changed in the skin surface. It doesn't tell me, it doesn't show that all the fat I put is here in the blue side. No, this is measurements in millimeters. It shows the change in the skin surfaces. So it's a nice, you can also play with it, but it does give you some information. So some examples to try to keep in my 17 or 18 minutes. Here's the same lady I already showed you with a very high upper border of her breast. She was 35 when she came to me, mother of 3, and she told me that this has never been my body image. I don't want to look like this. All the other ladies in her family were really big-breasted. So I did a dual plane submuscular anatomic 295cc implant. I always use, well, let's say 99%, I use the inframammary fold incision. And here she is 1 year after. Same patient, before, 1 year after. An oblique view. She was very happy with the result, and so I'm happy with this. But it was funny because when I asked her, because it's quite a big change at the breast size, and I asked her later on that when did you start to feel like that these are really your breasts? When did you feel that this is really your body image? Because the change is quite big, as you can see. And she was one of the patients that told me when I woke up from the anesthesia. She felt that now I have the breast that I always ought to have. So she was a very happy, satisfied patient. And another example, also 34 years old, mother of 4, very bad skin quality, as you can see after breastfeeding feeding. And again here, anatomics, dual base submuscular 375cc implant, 1.5 years after. And she actually had a quite sad story. Because of her small breast, she had been harassed at school, starting from a quite early age. So she actually got sick with anorexia because of this, was sick for many years. And then when she came to me after 4 children, I actually asked her to come and see me for a second time because I want to be absolutely sure that she's psychologically stable, because I couldn't promise her that nobody will ever tease her again, even when I put the implants on. But anyhow, she was happy with the result, so am I. Here we go, different positions. And the last one for implant augmentation, completely different structure, completely different story. She's 28 years old, no children. And look at that, how full the inferior pole is, how long the distance is, and how flat she is here. And where is the upper border? Very low. So I took this into account, and I think I get a reasonably good result for her. So dual plane, submuscular, anatomic 295 cc's, 1 year after. Same from the side, oblique view, oblique view. Okay, when do I go to mastopexy augmentation? Well, I think Per told us all already. This is quite clear case. You can't correct this with a implant only. But she didn't want the vertical scar, which I usually use. I do use quite a similar technique to ProHead. So I did a compromise with her that, okay, I can try to correct the laxity of her skin by periareolar excision only, which I did. And she was very happy with this result. Well, I think it's a reasonably good result. She's 84.
Katja, I think we have to try to...
Yes, okay, 48 years old. And this is my last example from fat grafting. A lady with a very bad, a very clear asymmetry, didn't want any implants. So in 2 sessions, fat grafting on the right, altogether 500, and on the left, 275 milliliters. There was, after the first session, this is a picture 6 months after, this is 3 months after the second session, and there was 1 year apart because she's traveling a lot. I would like to graft her a 3rd time here, but she's happy with the results, so we won't be doing that. Same. So, second last slide, as I talk about the fat courses, we are organizing one now in September in Helsinki. The subject is hair transplantation, and visiting professor is Dr. Alfonso Barrera from Houston. And you can find the program on the webpage address over there, and please join us. You're all welcome. Thank you. That was only 17.5 minutes.
Thank you.